Good evening and a warm welcome to Expert Talk series. My name is Akil Rashid and I am the Research and Knowledge Hub Chief at Jammu and Kashmir Policy Institute. I will start today's session and introduce the speaker. Jammu and Kashmir Policy Institute has initiated the Expert Talk series to engage experts, changemakers, pioneers from various walks of life to understand the dynamic context of implementing the UN Sustainable Development Goals on its agenda. The vision and intention of the Expert Talk series is to source inputs, recommendations from experts in various fields pertaining to different sustainable development goals through one-on-one dialogues. Today's session is a part of the Expert Talk series on SDG 3, good health and well-being, and the impact of COVID-19. We have successfully concluded 24 sessions in the Expert Talk series with a focus on SDG 3 and 5. Today, we are delighted to be joined by Dr. Mohammad Ashraf Ganai, who is Professor, Department of Endocrinology and Metabolism, Subdean Research, Sher Kashmir Institute of Medical Sciences, Sura, Srinagar. Dr. Ashraf is also the President of Metabolic Syndrome, Pre-Diabetes, Polycystic Ovary Syndrome Society. He was formerly Associate Professor, Department of Endocrinology and Metabolism, All India Institute of Medical Sciences, New Delhi. We are live streaming an important conversation with Dr. Mohammad Ashraf Ganai that will elicit a discussion on the pressing issue, increasing cases of diabetes among children and youth in J&K. We believe his vast experience and knowledge would be highly beneficial for our audience. On behalf of the entire team of JKPI, I welcome you, sir. Thank you very much for taking the time to be with us. Now, I would like to pass on the mantle to Tanveer. He will facilitate the session. Thank you.
Thank you. Good evening, everyone. Thank you, Akil. Thank you so much for the introduction. As Akil already told that it's 25th session of the Expert Talk series, and it's almost a year now since we have been conducting this Expert Talk series. And we have got very good response from all walks of life regarding the Expert Talk series, and people ask us to go for more such sessions. And today is an important session, and Dr. Ashraf will share his insights regarding the same. So as we have only 1 hour for the session, so as we all know, 1 hour is never going to be enough for such a vast discussion. So let's start with the first question. Dr. Ashraf, my first question to you is, what is the present scenario of diabetes among youth in Jammu and Kashmir?
First of all, let me express my thanks to the JK Policy Institute and Young Dynamic team, Mr. Akil, Tanveer, Jigyasa, and others. So I would actually like to share a few of my slides to give you actual idea to the audience for this, because I believe that there must be audience which is from different walks of life. So some basic understanding is required about the disease. However, before I start sharing my slides, let me answer your first question. Because the diabetes in young is of 2 types. So one is either it could be a type 1 diabetes mellitus or type 2 diabetes mellitus. So type 2 diabetes mellitus in young has shown a recent increase in global, Indian scenario, as well as in our J&K, whether it is Ladakh, Jammu and Kashmir, because of the several reasons, because of several lifestyle changes. However, having said that, we do have shortcoming of the data, actual scientific data from our place. We don't have clear-cut data that whether this diabetes in youth has actually gone up and what are its risk factors. Nevertheless, we have some indirect reasons, indirect risk factors, which we can actually explain in few of my next slides, that why it has started going up. So if you allow me that I can share few of my slides, so that while I'm showing my slides, then questions can come and I can keep on responding.
Sir, you can share. I've given you the authority.
Okay. Mm. I hope my slides are visible.
Yes.
Yes, sir. They are, sir.
Yeah, okay. So as Dr. Tanvi rightly said, that this is a very vast topic. 1 hour is inception, but I'll try to give you some basic idea why there is rising trend of diabetes in young world over as well as in our place. So if you can see that I have put in some slide on the left side that there is some central phenomena which is happening is called insulin resistance syndrome. This insulin resistance syndrome is linked to so many disorders which we call as lifestyle disorders. So diabetes is one of the lifestyle diseases, as you know. Diabetes is a chronic disease and it occurs because of dysfunction in pancreas. Pancreas, you know, is an organ which is located just behind stomach and it has two parts. One is endocrine and exocrine pancreas. The endocrine part contains different cells. Some are alpha cells, beta cells, delta cells. The beta cell is known to be the machinery of a very, very pivotal hormone called insulin. You must have heard insulin is a hormone. This hormone regulates the protein, carbohydrate metabolism in the body, even fat metabolism. And this insulin molecule has a very important function that it transports glucose from blood to the cell. So glucose is the final machinery, final energy source to our body. And every food component which we take, our body metabolizes it, converts it finally into glucose, and glucose is the molecule which enters into cell and gives us energy. And insulin is a carrier which takes this glucose into cell for final breakdown. So that way insulin is a very important hormone. So when diabetes occurs, diabetes can occur either this insulin molecule is absent from the pancreas or this insulin molecule is not able to act on the cells. So that is how diabetes occurs. So high level of glucose in the blood because of either ineffectiveness of insulin or absence of insulin causes diabetes. And the level which we take for qualifying diabetes is 100 milligrams and above is abnormal. When we take a fasting plasma glucose, in a fasting state means you have to be fasting 8 to 10 hours, or if you eat something and 2 hours after eating, what is called as postprandial state, if the glucose is more than 140, it is abnormal. Now, American Diabetes Association and other finding agencies say that if HbA1c crosses 5.7, that is also abnormal. So this abnormal value of fasting glucose, postprandial glucose, or HbA1c makes it either pre-diabetes and diabetes. Now, if you can see in my slide on the right side, if a fasting plasma glucose crosses 126, it is called as diabetes. If it crosses 200 after eating, that is diabetes. If HbA1c is above 6.5, that is diabetes. Between the abnormal values and this, we call whole spectrum as pre-diabetes. So we should know before understanding why type 2 diabetes mellitus is happening in young, We should know what are the definitions. And if we want to see what is the natural history of diabetes in children or adults, if you see that actually diabetes starts at some point in an adult or a child, on an average, 10 years before, the disease risk factors start acting. Those risk factors are either obesity or insulin resistance. And when you have insulin resistance, insulin resistance means insulin molecule is not able to act on the cell. There is some problem. The commonest cause is overweight or obesity. When this happens, you get metabolic syndrome. And when glucose levels cross the cutoffs, as I showed you in the previous slide, then we call it the onset of diabetes. If this diabetes means hyperglycemia, high glucose level is not taken care of, you have associated high blood pressure, atherosclerosis, and this ongoing high glucose level starts damaging tissues, especially the vessels, either small vessels or large blood vessels. They are called as micro or macro angiopathy, and that leads to either kidney disease called as renal failure, nephropathy, or eye disease called as retinopathy, or heart disease called as coronary artery disease, foot disease, and so on. So diabetes causes several complications. So why does this diabetes occur? Why does insulin resistance occur? As I already said, this pancreas situated in the behind stomach has these beta cells, and these beta cells secrete insulin. This insulin acts on liver, muscle, fat, and control all the glucose metabolism. And if there happens to be obesity, or there happens to be some reason of stress, you have stress, or you have less physical activity, or your age is going up, you are elderly, or you take diets which are high, rich in carbohydrate and fat, and then you have also some genetic factors, all these risk factors will lead to this insulin resistance, and finally you are at a risk of getting hyperglycemia, means diabetes, and this diabetes will finally lead to complications of the organs. As I said, diabetes has two types. Type 1 diabetes mellitus happens simply because you have some viral attack or autoimmune attack on these beta cells. It comes instantaneously, and fortunately type 1 diabetes is very rare. It happens in younger children. They are thin, lean, and if we don't treat this disease with insulin, they go into diabetic ketoacidosis, and it is a life-threatening disease if not treated by insulin. But problem with our population is not type 1, is not that big an issue. The problem on economy is type 2 diabetes mellitus. So what is type 2? It is that insulin is probably present, but it is not effective on the cells. So as I told you, there are several risk factors. Either you have family history of diabetes, either you have physical inactivity, you are taking a lot of diet, you have stress factors, and then you have so many what is called endocrine disruptor chemicals, like you use plastics, you have pesticides, several things have been incriminated into it that leads to this type 2 diabetes mellitus. So there are some differences in type 1, type 2. I will not go in detail. If somebody asks a specific question, I will come back to this slide. Now, as I told you, when you have this beta cell defect or insulin resistance, this happens with age or obesity or high blood pressure, dyslipidemia, sedentary lifestyle. Your ethnicity means Asians or Indians are at more risk, and if you have genes suggestive of that, you may have, if you, in women you have polycystic ovary disease, all these will lead to type 2 diabetes mellitus, and it can happen in pregnancy. This is called as gestational diabetes mellitus. It can also happen in some families as a rare form that is called MODY, maturity onset of diabetes of young. So why does type 2 diabetes happen in children nowadays? All of you must have heard that type 2 diabetes happens in adults. But in recent years, in last 1 to 2 decades, there has been a trend that type 2 diabetes mellitus comes in children. There is a data from National Health and Nutrition Examination Survey. This survey is done in US. They do national surveys every 5 years. This is a big data source world over called National Health and Nutrition Examination Survey. And this survey gives us several other diseases, not only diabetes. So if we pick up the data from 1990 to 2002, 0.5% of adolescents in US had type 2 diabetes mellitus. And 71% had type 1 and 29% had type 2 there. But if you see, the paradigm is reverse here. We have type 2 higher. So this was a way back in 2002. If you see today, it has shown a rise in 41% rise in type 2 diabetes mellitus in that population. Now, if we see in India, our some data from Karachi, Pakistan, Bangladesh, Chennai, India, Delhi, India, done by a few of my colleagues when I was in AIMS, New Delhi, we found that data gives almost 20 to 25% of people in these urban cities have diabetes, and almost 5% have type 2 diabetes mellitus in school children, young children. And why does that happen? That happens because of some factors which I will explain. Now, if you see this slide, in India, even today, 40% of children are undernourished. They have several diseases, we know that, but still they are undernourished, means they are not able to get adequate food. But if you see our observation, which we have been doing, we have done 108,000 children survey in various government and private schools across India. If you see this data here, in government schools, only 2.6% were overweight, only 4.42% were obese boys. And in girls, percentage was a little higher, 2.14 versus 0.28. But if you see private schools, like all the fee-paying schools, the percentage of overweight and obesity is 16% overweight, 5.5% obesity. And if you see in girls, that is even higher, 19%. That means every fourth girl or every third girl is either overweight and obese. So this is actually a big reason to worry in India, that most of our children now go to private schools, and the nutrition, the type of lifestyle they are sedentary. They watch games, they watch TV, they use gadgets, they don't do any exercise. Instead of doing the exercises in the playground, they do exercise on the mobile. And that is the scenario which has happened, is growing fast in India, and our J&K, UTF, J&K is not an exception. And most of children are addicted to these games. And that is the reason of this rise in the overweight and obesity. And as I said in the previous slide, this overweight and obesity is a very, very close parallel phenomena to the diabetes. If you see in this slide, so I showed you a slide on undernutrition. As we see the children like this picture from Africa, that there is no nutrition available. These are fasting children, they get undernourished, and while as some children here get overnourished. And we have a double whammy in our country, means we have both undernourishment and overnourishment. It is unlike the Europe and Americas and the West developed countries. They have childhood obesity, but they don't have undernourishment, they don't have diarrhea, they have full vaccination, they don't have the other diseases which affect in children. We have those diseases which cause mortality, infant mortality, childhood mortalities, and morbidities, but we also have these non-communicable diseases, lifestyle diseases, where diabetes is and obesity is one of the important parameters. I would like your attention to be paid to this slide. This is the data from US. If you see, although an old slide adopted in 2000, it shows that if you see the upper graph shows this orange one, that this is the little drop over the years from 1900 to 2000, over 100 years, there has been a drop in some diseases. But if you see this line, the brown line, there has been a steep drop until 1960s, and then it has touched the baseline in USA. These are infections because they started giving antibiotic and vaccines, so everybody, infections are virtually eradicated, except any sporadic infection like COVID-19 came this year. Some other infection came. Most of infections they have been able to control. But some diseases they are also not able to control. That is why there is this graph still rising, stable, this middle one. So this is because non-communicable diseases, mean lifestyle diseases, they are not able to take care. But in our countries, lower and middle economic countries like India, we are not able to take care of both the disease sets, infectious diseases as well as non-communicable diseases, because this is a behavioral issue in our populations. If you see in the slide, the behavior means diet, physical activity, and other factors. If you see the lifestyle, we have started copying West, like the food chains are fast spreading in our population. If you see in our town, in our Srinagar city, I will show you, if you start every 100 meters, you will find a shop which is a food chain. Every other 200 meters, you will find a mobile shop, and you will not find a bookshop. Possibly you may find one, and you will not have, so you will have dress, food, and mobile shops. So then there are a lot of vehicle shops. So that means, what does this tell us? It tells us a story of behavior of public. It tells you what people demand. That people demand is depicted in the market. You can easily survey, and that is the demand from public. And this is a probably people think we have now progressed. We have shown progression. We have developed economically, but actually that is a very limited development in terms of we are getting overnutrition, sedentary lifestyle, smoking, bad habit, road traffic accidents, and several other things we target. So realizing this fact, in 2010, Michelle Obama, actually from US, from the White House, launched a task force in 2010. That task force was childhood obesity program. They stopped all the food outlets in schools so that they believe that an obese child will always be an obese adult. A diabetic child will always be an obese diabetic adult. So if you are able to tackle these lifestyle problems in youth, in young, probably the disease burden in adults will be also less. So we know how diabetes is caused. These are risk factors. Now I want to tell you in few slides quickly, how does diabetes present? We know diabetes has some symptoms. Main symptoms are, if your sugars are very high, it may cause weight loss, it may cause increased appetite, increased thirst, we call as polydipsia, polyuria, and you may get fatigue, and you may have more urination, and these are some symptoms. You may get visual problems, but most of times you should know that diabetes doesn't give symptoms unless it is too late. It may give skin lesions, it may give vaginal infections, other infections, ulcers, but these are symptoms which present very late. Actually, diabetes has to be detected by testing. You have to do screening. It doesn't have symptoms. It is a symptomless disease in 80% of people. And why diabetes should be detected early? we know, everybody knows that it causes a whole set of acute or chronic complications. Almost every organ in the body, wherever blood flows, wherever the blood vessel goes, it is getting impacted negatively by high glucose, means diabetes. As you see in the slide, you have blood vessels wherever they are. Every organ, eye, heart, blood vessel, kidney, liver, reproductive organs, everything gets affected. So you may have kidney failure, you may have amputations of legs, you may have heart attacks and strokes, you may have, God forbid, blindness, you may become, you may have several other issues, and finally, God forbid, people die if they are not morbid. This is one of the picture I am showing what happens in the eye inside, what happens because of nerves to the muscles, you get weakness. What happens, gangrene happens when blood cell gets blocked, your foot may have gangrene and you may have to amputate the foot. You may have disorganized foot called as Charcot's foot. You may have skin diseases like this. You may have other lesions skin. You may have stiffness joint. This is called prayer sign or namaste sign. You cannot fold your hands. So you may have, if mother is pregnant, has diabetes, you may get big baby. That is called macrosomia. And this baby is at risk of future development of diabetes, obesity, hypertension, and so on. So as in Jammu and Kashmir, we speak about, as your question was, we speak that we are also trying to see at AIMS New Delhi, we had a young diabetes clinic. We had type 1 and type 2 diabetes mellitus. Similarly, we have been trying to see at SKIMS also that we have a young diabetes registry. Although there are not many people yet registered, but we have started getting data. And in like this is the data from our clinic from All India Institute of Medical Sciences, almost more than 5,000 young people admitted, registered in our clinic, which we run on Saturdays, and 63% had type 1, almost 25% have type 2. But if I can share with you, 20 years down the line, when I was a student of DM trainee at AIMS New Delhi, we had hardly 1% type 2 diabetes mellitus in these children. So it means in 20 years, the percentage has gone to 25 and it is rising. Means type 2 diabetes in children is rising, it is going to go up. And this is the same IDR registration, that this is how type 1 is common, but type 2 diabetes is also rising. It is going to go up. So in our Jammu and Kashmir, we have also tried to screen population. We are doing population screening camps in schools, in colleges, and even in some communities. Especially, I have been doing for last 10, 15 years, surveys in tribal population. So we have some data from tribals also, which I'll share. For example, we have some specific type of genetic diabetes also. We have reported this paper, which has been published in Diabetic Medicine, which is a British Diabetes Association journal. We found that there is a sort of a disease in young where you have deafness, eye problems, and diabetes from the beginning. And it runs in families because of genetic problems are common here. So this is where they get brain involvement, they get all other several organ involvement, they get blindness also. So similarly, we have reported in young women who have Pcos, even those teens, they are in the age of 20, 30, they have almost 50% chances of having prediabetes and diabetes. Those girls who have obesity, they have hair growth, they have menstrual irregularity, we call this as PCOD, they have very high prevalence of diabetes. We have also something called TRMA. This is another type of diabetes. It's a genetic diabetes. You have deafness in children and you have diabetes. These are some uncommon diabetes. I just want to show you slides. So as I told you, we have done these tribal surveys in Gujar and Bakarwal population. We have been seeing more than thousands of Gujars and Bakarwals. We are also doing some intervention programs in J&K, Ladakh. And I see there is actually high prevalence, although diabetes in our tribal population is not that high. But what is alarming, that 11 to 12% of tribal population have prediabetes. Means if we are not going to take care of even Gujar and Bakarwalas who are thin, they don't have obesity, they are going to convert this pre-diabetes into diabetes in near future. So I will stop here. I will say something about prevention later on. I would like to have your questions on the risk factors, presentation of diabetes, and the prevalence, what I have covered. Then I can take those questions. Then we'll go on prevention and treatment subsequently, if time permits.
Thank you, Dr. Saab. Thank you so much. तो एक क्वेश्चन के आपने बहुत सारे आंसर्स दिए, आपने सिर्फ एक इशू एड्रेस नहीं किया, आपने बहुत सारे इश्यूज एड्रेस किए. तो जैसा पहले ही हमने बोला था कि 1 घंटा काफी नहीं है ऐसे डिस्कशन के लिए, तो हम मोस्टली जंप करेंगे जो कुछ क्वेश्चन सोशल मीडिया पे अभी हमें आ रहे हैं. तो डॉक्टर साहब, देयर इज वन क्वेश्चन, व्हाट आर द वार्निंग साइंस और सिम्टम्स दैट माय ब्लड शुगर्स आर टू हाई? व्हाट डू आई डू इफ माय ब्लड शुगर्स आर टू हाई?
Very good. It's a correct question. See, when I was a student 20-30 years back, the teachers would teach us that if you have polyuria, polydipsia, polyphagia, 3 P's. What does polyuria mean? आपको urination ज़्यादा है. Polydipsia means आपको प्यास ज़्यादा लगती है. Polyphagia means आपको भूख ज़्यादा लगती है. So these 3 symptoms were to be treated as diabetes. So now today, over the years, when we have understood these symptoms happen only in 10 to 15% of population. So as he has rightly asked the question, if my sugars are too high, means if your sugars are definitely, if these sugars are definitely high, means if they are more than 200, 300, 400, then you will have symptoms. Means you will have these symptoms which I described, polyuria, polydipsia, polyphagia, but diabetes can have any other symptom. Like if you have a high sugar, very high sugar, you may get visual problem. You may have problem in reading, writing, or you may have blurring of vision. Or if you may have skin lesions, itching, fungal infections. You may have genital infections, both in men and women. You may have sometimes problems with the kidney, sometimes problems with the heart, sometimes problems, you may have gallbladder surgery. So patients may get detected routinely when you do a routine test. So there are several symptoms of diabetes, but if somebody has fatigue, if somebody has weight loss, has little bit of blurring of vision, has to nocturia, means has to get for urination during night, gets hungry, one should be alarmed and get a blood sugar test done. Not only that, don't wait for symptoms. If you are about 35 years of age, if you are obese, if you are any family member has diabetes, if you are a girl with PCOS, if you have high blood pressure, and in these situations, you should get a blood sugar test done once in a year.
Thank you, Dr. Sir. Thank you so much. So we have one more question. This is Ruda asking, I'm asking this question for my mother who is 65 and is a diabetic. Is it true that diabetics are more prone to glaucoma? And what could be the early signs so that it can be prevented?
See, very good. The slide I displayed here, I'll just show you. This is a slide what she is asking about glaucoma. This is the slide. This patient has diabetes and has a glaucoma. So that is exactly what happens in the eye. Patients with diabetes get vascular anomalies in the eyes. Of course, with advanced disease, they will get glaucoma. So that is why there is a recommendation in type 2 diabetes people. We do an eye checkup every year. So if there are any signs of vascular anomalies, we do various treatment strategies, whether it is laser, whether it is injection, whether it is any medication that is done. So pick this eye problem earlier, we do a yearly checkup.
Thank you, Dr. Sir. So before we move ahead with these questions, I have one question for you regarding the policy making. So maybe I join these two questions. So what policy change could be adopted by policymakers to improve the situation, leading to sustainable change?
Absolutely. This is a very good question. See, policy changes, I may say, but on ground, these are not easy. See, when I will give a huge list of problems, but it is very easy to name problems, but giving solutions is not that easy. First of all, as I said, the risk factors for these type 2 diabetes mellitus in youth, not only type 2 diabetes, other lifestyle diseases, which will include obesity, high blood pressure, fatty liver, sleep disorder, breathing, then coronary artery disease, young heart attacks. These all disorders are the spectrum of same problem. Say if somebody has a fatty liver, and that goes to chronic liver disease. Somebody has a high blood pressure that leads to stroke. Somebody has a problem in heart, atherosclerosis, that goes to heart attack. All these diseases have a one single risk factor. Big risk factor is a lifestyle change. No doubt we may have a genetic predilection, like some genes may predispose you to, but genes are unmodifiable. I cannot do anything about my genes. Whatever I have got from my father or mother, I cannot modify them. They are there. Now what I can do, I can modify my lifestyle so that the influence of the genes is less. So how I can modify? I have to be active. Active means I don't have to be sedentary. I have to exercise daily, be whatever, my profession, I have to spend some 30 to 40 minutes a day or 150 minutes per week in active activity. That means either you do exercise or do you some field work depending upon your profession, so that you should have to waste, or you can say spend those calories which you are consuming. That is one. Second and most important thing is you have to avoid eating foods which have high calories. For example, we take carbohydrate, you have to take chips, you take burgers, you take Coke, which have high sugar content. So you take so many drinks, then you take softies, you have all the bakery shops available, then you take non-veg. And there is one thing, that these calories means the energy in these foods is very high. They are energy dense foods. So we take quantity more than required for our daily activity. So if we are taking excess calories, they are going to predispose us to obesity and insulin resistance, diabetes, heart attack and all. Number one. Number two. Number three, whatever food we are taking, we have to ensure this food is healthy, organic. This is not adulterated. And like we have these cheap oils available in these food chains. And these food chains are always trying to economize. They want to spend less money. They want to earn more. And all those food chains have very inferior quality items there too. Although they are looking good, package is very nice, the presentation is very good, it is attractive to the youth, children, and it is very attractive, but the content therein is not very good. So if I tell you that you reduce these food chains, if you put taxation on these foods, legislation should be put in, there is a political will required. Government has to do something about it. An individual cannot do. NGOs, public has to be aware of this, about these things happening. Another thing is that we use plastics. All these food items are carried in plastic bags, plastic tins. Then you have all the food, vegetables and fruit which we take. Although I advise most of my patients, that you should take a lot of fresh fruit and vegetable. But if you see those vegetable and fruit also have a problem. Most of fruit are now plastic coating. In order to retain the moisture, there is a plastic coating. There is a pesticide use. The content of pesticide is very high in them. So there we call these chemicals as endocrine disruptor chemicals. These chemicals, whether these are plasticizers or they are pesticides, when they go in our body in smaller quantities, they accumulate in our fat. And these chemicals change our endocrine signals in the body. This is called endocrine disruption. And they don't only cause these lifestyle diseases. The most important lifestyle disease, which I didn't say in those previous lists, is cancer. All the cancers now are considered, almost 99% are lifestyle diseases. So cancer happens because of these chemicals, these food items, which are consumed in smaller quantities over the years. And that causes endocrine disruption, and they lead to unregulated cell growth in our body, and that causes cancer. So what is the solution? Is like, if we make people aware, if we raise data, like I showed you, that tribal data and school data, if we raise data, we do research, we do surveys, very quality, good quality research, and then pass those good quality research papers from journals to the government, to the policymakers. Tell them, please see, this is the scenario of public. This is what is happening. We are doing industrialization. We are promoting the industry. We are promoting people on one hand, but on the other hand, we are trying to, it is telling upon our health. So we have to balance our lifestyle. These feedback should be given to the government. Government can make legislations, they can levy taxations on these items. And when more and more importantly, our youth, school children, they get aware of this, they actually minimize these, they fall less victim to the these so-called lifestyle issues. Probably we may be able to curb these diseases. This is very important. Prevention is very important in our country, especially all low and middle income countries. Why? Because our health budgets are very low. I can tell you that the health budget which India is keeping every year is 1/7 of what the bill will go for diabetes in this country. Diabetes management will have a bill, diabetes will be 7 times the health budget allocated in this country. So as an expert, as a person who has been seeing this both from clinical sides in clinics, my patients, and in the community as my the population, and in our lab, our research findings, if we see all three things together, that we need to actually make a sort of a vigorous campaign at the mass level to curb these issues.
Really valuable insights and suggestions, Dr. Saab. So before we move ahead, आप सबको पता होना चाहिए कि diabetes जो है 537 million people are globally affected by this disease, and which the number is going to rise by to 643 million by 2030. So this is a survey conducted by this International Diabetes Federation. So we have lots and lots of questions with very less time remaining. So I have one question. Maybe Dr. Saab has answered this. Does high carb diet put you on a high risk of diabetes? So this question has already been answered by Dr. Saab. We have another question. What are long-term health implications if a person has diabetes?
See, that also remains answered. We know that if your glucose is not well controlled, see, it depends upon your long-term health. How health outcomes will depend upon how normal you have been able to maintain your blood glucose. So those people who are not well controlled, they get within 5 years kidney problem, eye problem. Within 10 years, they get heart vessel problem. So you have stroke, you have heart attack, you have foot disease, as I show, gangrene, you may have to get amputation, you may get renal failure, kidney failure, you may have to get kidney transplant or dialysis. And if your heart vessel gets blocked, you get heart attack, you have to put stents, and so on. So almost every organ gets affected. by diabetes. So now, first of all, we should try to prevent it, because prevention is easier than cure and less costlier than cure. If you're not able to prevent, then when it has happened, then you have to do what is called secondary prevention, means you have to prevent the complications from occurring. That will be done if you are controlling it with the normal range. So the idea of preventing these long-term consequences is that you have to control the glucose well.
बिल्कुल सही. तो डॉक्टर साहब, इंटरनेशनल डायबिटीज फेडरेशन की जो सर्वे थी, इसमें ये पाया कि 1 in 6 live births are affected by diabetes. So are there any precautions for the pregnant woman?
See, actually, thanks Tanvir, you read the statistics from IDF. See, in fact, what IDF has proposed, let me tell for India, out of 11 people, 1 is diabetic in the world. Okay, if you see in Asia, it is only out of 9, 1 is diabetic, because China is the diabetic capital today. Soon India is going to be the diabetic capital. Now, if you see, out of 80%, out of total diabetics, 80% diabetics live in the low and middle income countries. This is a paradox. We thought initially it was thought that diabetes is a disease of rich people. It is not true. So rich countries like Europe, America, they have still lesser diabetes. See, diabetes in my tribal population, Gujar and Bakarwalas of Kashmir, have same proportion as the diabetes in European countries, because they take Mediterranean diet. Mediterranean diet is more seafood, more vegetable, and less of fat and carbohydrate. So that is why there is diabetes less. Our tribal population, who virtually don't eat anything, they are active people, they are thin, they also have so much of diabetes. So what I want to tell you, that these statistics, what IDF tells you, in India, they have surpassed. India, we were saying 78 million are diabetes, and we will have some 80 million in 2030. No, today only we have 80 million diabetes. I am involved in a survey. We are doing a study. We will soon start in J&K Ladakh. That is called INDIAP, Indian Diabetes, ICMR Diabetes Survey. It has been almost completed in all UTs and states. Now we have Goa, J&K, Ladakh, and Puducherry. These 4 we are doing these days, and I am the principal investigator here for J&K and Ladakh. So we are doing this survey. We will start it inshallah next month. But before that also, I have done some survey, as I told you, that diabetes is what were the projected values which IDF was giving. It is surpassing that. So probably we have more numbers today only than what IDF tells us.
So Doctor, we have just a few minutes left. So before we wrap up, one last question. It's Ulvi asking why insulin sensitivity is higher in women and how it is related to PCOS in them.
So as I said, that polycystic ovary disease was considered to be as a reproductive disorder. By many people, they thought it's a just gynae problem, and they would visit to gynecologists, say take some tablets and regularize cycles. No, but currently so much of research has gone into it. Pcos is not a metabolic, it's a metabolic disorder. It is just like diabetes. We can say, I don't believe that it is a reproductive condition. In fact, I have been working in this area, and I have put a debate at international level that it is a diabetes, early form of diabetes only, because the insulin resistance in these girls starts very early. And when these girls get obese, and they develop diabetes, and that diabetes has same consequences as any diabetes. Here, as the previous question you asked, that gestational diabetes means diabetes in mother. When it happens in mother, what happens to the baby? So same thing, if a PCOS woman has insulin resistance, she becomes diabetic, or if she is not diabetic, she conceives, she turns diabetic during pregnancy. That baby, which is in the womb of mother, that metabolism got changed, that the baby is at risk of diabetes in the later part of life. So I will just give 2-3 slides more, just tell you how to prevent. See, one of the prevention, if you can see my slide, is that we have to have a food pyramid. As I told you, you have a Mediterranean diet. If you can see, they use meat, sweets, carbohydrates, very little. They use more seafood. They use a lot of vegetables and fruit, and that is actually a healthy diet for them. That is why in the top, fats, oils should be minimized, while as you should take cereals, pasta, crackers, whatever staple diet. You can take more, but you have to be active also. In addition to your diet, you have to be active. Similarly, you have a physical activity pyramid. There are some listed activities. You should do minimum TV watching and video games and other things, while as you should do maximum vigorous exercise. So that gives a one nutshell message with this picture, that how we can change your program, lifestyle program. There are some programs being done in the West. They use metformin, thiazolidine to prevent diabetes in young. So there are a lot of treatment goals there put in. And in West, they have put a national diabetes education program for children. They put these programs in schools, and they help students how to prevent diabetes. Although there are these gadgets available, pumps, pens, vagara, and stem cell treatment, but in youth, the best would be for our country to prevent. So that is why I will conclude with this slide, that the increased incidence is evident from data. It is difficult to distinguish type 1 from type 2 diabetes. This type 2 diabetes in youth is part of non-communicable diseases. There is a strong family association. There is a rapid progression of complications in these population. So we should put public awareness, mass education to prevent this. Government should come in this school-based programs, and legislation and taxation should be done. And policy, JK Policy Institute should keep it up. They should do more programs for educating our masses, and simultaneously passing on this message to the policymakers for circumventing the lifestyle changes. Thank you very much.
Thank you, Dr. It was indeed an enlightening session. So as we are out of time, so we have one more question, Dr. Saab. Can I go ahead with just a small question, please? So it's Zahur asking, I am curious to understand, why is there lack of social medicine and counseling programs in addressing the exponential rise of diabetes in youth?
Zahur Saab has asked a very pertinent question, but let me tell you that government is trying, because government doesn't have that much resources. Government has a population of 1.5 billion to tackle. So much diabetes. Policymakers are also at a loss. Nevertheless, government has started a program, what is called NHM, National Health Mission. There is a program NCPDS, Non-Communicable Prevention Program. There are 75,500 wellness centers created in the country, health and wellness state. So they are trying to put ASHA, health and wellness centers in the periphery. And then there are those bridge, what is called alternative medicine people are also there. So they want to put them and teach people how to prevent these disorders. But there is a problem. There is a lack of manpower. There is a lack of budget. See, I will tell you, people have to get active. People have to start it in a mission mode. Public have to get involved. I will tell you a good news. I have myself initiated a program of diabetes educator. In the country, there is no diabetes educator program. So we have started January 1st, 2022, Kashmir University and Sikkim will launch a diabetes educator program. That is already advertised. We will have science graduates trained for 1 year, taught for 1 year, and made diabetes educators. So we are trying to start a model program which will replicate in the country. These programs will be actually put in everywhere, so that these diabetes educators will also help people, educate people in prevention as well as treatment. Because we cannot have endocrinologists and diabetologists in so many numbers which will reach to all people. That is not possible.
बहुत अच्छी बात की आपने डॉक्टर साहब, जो प्रोग्राम्स की आपने बात की, इससे मासेस में जो एजुकेशन होगी डायबिटीज को रिलेटेड वो बहुत एम्पलीफाई हो जाएगी. So it was really an enlightful session. Thank you so much. So with this, I would like to end this session, and I would like to ask my colleague, Mr. Akil, to present the vote of thanks. Akil, you are on mute. Please unmute yourself.
Thanks, Tanveer, for hosting an important conversation tonight, and thank you for asking the urgent questions. The session with Dr. Ashraf was very informative, and it's needless to say a comprehensive evaluation of the discussion is not possible given the time constraints. However, here are two key takeaways for me. One is we cannot modify the genes, but we can modify our lifestyle. And another is prevention is easier than cure and less costlier than cure. Now, I would like to thank Dr. Ashraf Sahab on behalf of the JKPI and the audience. I would like to thank him for making an excellent presentation and making the session very enlightening. Thank you for sharing with us your very interesting and thought-provoking insights. I'm sure that all the participants have taken note of your suggestions and will try to act on them. As we will stop the live broadcast, I request Dr. Ashraf to stay back for a very brief intro with the JKPI team. Thank you.
Thank you.